Good evening, everyone, and thank you for joining us for NextBreath 2023. My name is Ashley Locke, and I will be here to give you some insight on life post-transplant and also give some background information about my personal transplant story as it was an emergent transplant. And I also will be touching on the research that has gone into CF throughout the decades. So I have a paper here that I'm going to read from. If you don't mind, I will put it right up here against my screen. And I will get started here. My name is Ashley Locke, and I am 30 years old, currently living in Lower Michigan. I was diagnosed with cystic fibrosis at 2 years old. You may also remember me from this year's BreatheCon for the CF Foundation as host of our People of Color room. Growing up, I felt like I had the triple threat of minorities: chronically ill, biracial, and LGBTQ. It's hard enough to go through life and find your identity, but imagine that entire time your body was actively trying to kill you in some way every year to top it all off. I have been going to the University of Michigan CF Center since my young diagnosis, from pediatrics to eventually graduating to the transplant center. The U of M staff have seen me through several medical miracles, which includes my appendix bursting 2 separate times, an experimental surgery in 2018, and a life-saving double lung transplant in 2019. I'll be coming up on my 4 years post-transplant in 2 weeks on the 28th. I'm very excited about that. My transplant story isn't quite a typical one, as my team and I weren't aware just how fast my health was declining. I went from actively working 3 jobs one year to barely being able to make it from my bed to my bathroom the next. Within a 5-month span, I had 3 separate lung collapses. It was only 3 months after I had begun conversations about transplant when my right lung collapsed for the first time as I was driving down the highway at 70 miles per hour with a friend. Next slide, Carrie. That put me in a very serious situation very quickly. I drove myself to the ER, threw on my hazards, and went as fast as I could. I knew immediately from how I felt that I didn't have time to call an ambulance. By the time I made it to the ER check-in desk at a hospital I had never been to, I began blacking out from unable to breathe. Next slide, please. Thankfully, that team did what they could for me until I was stable enough to be transferred to my main CF hospital a week later. They would have taken me sooner, but they weren't sure if I would survive the 45-minute drive there. At U of M, I then waited another week as my CF team scrambled to figure out how to repair a large pneumothorax when I wasn't even listed for transplant yet. I had only taken 1 preliminary test and was far from being finished. I couldn't be listed until they were completed, but I needed help immediately. Next slide, please. Luckily for me, there was a doctor outside of my regular team circulating in the ICU, and he was interested in trying a procedure that had only been performed on one other CF patient ever, which included placing something called endobronchial pulmonary valves. It was a very scary time as I had to fill out a lot of paperwork that basically said, I understand that this is an experimental procedure and they cannot guarantee the outcome. I also filled out information for my will and power of attorney that day. The procedure was a success, and my right lung was able to heal itself over a span of time thanks to these valves called Zephyr spider valves, which allowed the holes to close and air flow freely through them. Because of this, it is maybe the first case to have these particular Zephyr spider valves placed. And today, that procedure is being used for more lung trauma patients to help aid in the repair of lungs and for CFers that have had lung damage pre-transplant. Unfortunately, after about 4 months later, my left lung became the struggle and eventually burst in two separate areas within a week span. The third and final lung collapse was the scariest, as there were two holes that were too large for the valve procedure to work. It was attempted, but it failed. I was in a lot of pain. We hoped it would maybe repair itself with some time, but both lungs were completely shot within 2 weeks. I needed a transplant and I needed it immediately. I had done pre-transplant testing in those 5 months, but was still not ready to be listed. Then one day, two of my biggest fears came true at the same time. I woke up on a ventilator and I had a GI tube, feeding tube placed in my stomach. My body was giving up quickly and wasn't able to function on its own anymore. Next slide, please. For a long time, it was touch and go. You hear the saying, a day at a time, but I truly knew how it felt to take things hour by hour. Some days, it was minute by minute. After some time, thanks to an amazing medical team, blessings from the universe, and being surrounded by loved ones, I began to stabilize the ventilator, and my numbers were starting to cooperate for a while. This also meant I was able to be taken out of the ICU, get the vent taken out, and have a tracheotomy performed. I gathered as much strength as I could from there and was able to complete the rest of my transplant prerequisites from my hospital room under moderate supervision while still on life support. I even had to train myself how to walk again due to losing so much muscle, and my weight was in the low 90s. I waited approximately only 1 month after being listed for my double lung transplant, and my team and I approved a suitable pair of lungs just for me. Due to it being an emergent situation, I was high on the transplant list, and it was all a blur of everyone working together to see me through this. I remember waking up afterwards expecting that dramatic moment when you open your eyes and take your first breath and it feels easier, but it didn't. It hurt a lot. Next slide, please. Not only my entire chest and rib cage, muscles and lungs, but everything else I went through during that time. Multiple ventilators, bronchoscopies, a trach, feeding tube, the testing for transplant. I had a port implanted a month prior, multiple chest tubes from the previous collapses. I could list so much more, but let's just say everything was on fire. More pokes, more prods, and a lot more willpower was needed. After a total of 2 months in the hospital, successfully being taken off the vent, able to walk a bit more, and beginning to get my voice back, I was finally able to go home. I shaved my head while still on life support after my transplant, and it's been a blast to watch my hair grow from nothing to what it is today as a visual, physical reminder of growth. I would love to share more of my story in the future, but I cannot thank the University of Michigan for seeing me through the hardest times in my life enough. I would not be here today if not for them and the amazing medical research teams. I try to live every day to the fullest, finding love and connection in all of its forms. Next slide, please. I have participated in research studies as often as I could growing up. I've helped test anything they've let me, from different enzymes to separate medications that go into Trikafta, and the most notable, having Zephyr pulmonary valves placed. Because of them, I have been able to travel extensively, go skydiving, next slide please, go skydiving, enjoy time hiking in the woods, and keep up with my favorite animals. I love to share more of my story with you all in hopes that it can shed some light on the different challenges cystic fibrosis can carry, how important CF doctors and researchers can be, to be informative about how quickly CF research is advancing, and how you can continue actively participating in your personal care. Today, I work primarily with animals, caring for their well-being, and I also have the privilege of working alongside other U of M staff as a medical advisory board member, where we discuss research advancements, improvements for patient care, and pull together information and resources for other U of M and CF patients alike. Thank you so much for listening to my And I would love to introduce you to my current transplant doctor from the University of Michigan, Dr. Rommel Sagana.
Thanks, Ashley, for inviting me. I'm very honored to be here to chat about lung transplant, and you're doing great. It was nice to see a reminder of all the things that you've gone through over the last 4 years. But your 4-year anniversary is coming up, and so congratulations.
Thank you. I appreciate it. Now, let me see here. I did have some questions that I would like to ask Dr. Sagana specifically. Now, I had mentioned in my speaking here that I was, because of the emergent situation, I was placed pretty high on the transplant list at U of M currently. Would you be able to tell everyone a bit more about the transplant list, the CSA scores, and how that works?
Sure. So most people who know anything about lung transplant in general knows there's this list that people get placed on. So to appreciate how the list has evolved, I'll just talk about how it used to be. So when lung transplant first started happening several decades ago, the list used to be what's called time-based. Like your doctor would feel that, yep, you should get on the list, because the longer you were on the list, that's how you moved up. But if you think about it, that's really unfair, because if someone has a disease that isn't that bad, but their doctor decides, well, let's just put you on the list early so that when you do need it, you'll be up there. That puts people who maybe weren't that sick before and thought they were okay, but then something happened, like Ashley, where something happened and all of a sudden they're really sick and they need a transplant right away. Well, if you weren't on that list sooner, then you're out of luck. You couldn't move up on that list. So they got rid of that system about 20 years ago with something called the lung allocation score. And that one was designed to try to be fairer to everyone. So there were different elements that would go into that score, like what kind of disease you had. So certain diseases like pulmonary fibrosis just inherently get sicker faster than other diseases. So if you had that, you got like more points to begin with than other disease types. And then they'd look at things like your oxygen use, how far you could go on your hall walk. And so all these different things, they'd plug them in there. And then eventually it would spit out a score. And the score would be like up to 100, but most people were probably between like 30s and 40s. That was kind of average, depending on what disease you had. And if you were in the hospital and sicker, could be higher than that. And so we did that for a number of years. But then when we took a closer look at it, it still didn't seem fair. There were some things that could be going on to the patient that wasn't reflected by that lung allocation score. So then this CAS came out, the Composite Allocation Score. And this just started a few months ago. And so the CAS tries to take into account those factors that I said, that it's not, wasn't captured before. So it's still out of 100. It is impossible to get 100 points. It's just not possible, like numerically how they calculate it. But the higher your point total is, the sicker you are and you're, quote, higher on the list. The biggest parts of the CAS are the type of disease you have and whether the likelihood based on your disease, based on everything about you, like how old you are, things like that, whether or not you'll live 5 years after transplant. That's like the half of the points. The other parts of the score take into account blood types. So if you have a rarer blood type, you get more points for that, because before it would be harder to find a match with a rare blood type, and it wasn't reflected on the score. If you had more antibodies when we're doing testing, having higher antibodies wasn't always taken into account. And so you get more points for that, and various other things. So this new system, the CAS, is designed to try to, again, be fair to people on the list, and who needs a transplant the most should have the best shot.
That's interesting, because I knew some of that, but I didn't know just how much really went into it.
Mm-hmm.
I do remember when I was listed, I was listed for maybe, I think, 2 or 3 days, and I went up to like number 8 on the list, which was pretty high out of, the area's list. So it's interesting to know how they calculate that. Another question would be, what are some reasons that can cause you to be taken off of a transplant list?
Sure. So the best way to be taken off of the list is to get your transplant. But outside of that, there are other things that can happen. So there's things that can happen that gets you put on hold and not completely off the list. So things that can get a person put on hold would be if you got a pneumonia or some other kind of infection, if you had to have emergency surgery for something else, say your appendix burst and you needed to do that. So take care of that first. So all those things will cause a person to be put on hold, and then we will evaluate the patient a little bit later to see if they're strong enough, if that problem has cleared up so that they can be put back on the list. Things that can happen to get a person off the list completely. It's rare, but someone can be too sick. And so I always tell my patients, you have to be sick enough to need a transplant, but if you're too sick, you won't survive a transplant. And it's a very fine line you have to walk. In Ashley's case, it was very fine. And so we have to look at that very carefully, because we don't want to tell someone you're too sick for your transplant. But so an example of that would be, I've had patients who just, for whatever reason, didn't contact us to let us know things were going on in their life and they weren't feeling well. And so by the time I saw them again, they were in a wheelchair and hadn't been able to move on their own for weeks to over a month. So those are the things that make me very sad, because if we know about things sooner, then we can try to work with the patient to try to turn things around. But that would be something that could get someone off the list permanently.
And that's interesting. Let me see. One moment here. Because I did have a question about that. I remember that there was a case maybe a year or two ago in my transplant group. There was a man. It's very common that you have to keep up with your mental health and your support system post-transplant, especially because as Stephen and our other keynotes were speaking of earlier, the first, when you're initially done, that you're going to be walking into a new life and things are going to be different, but there's so much to post-transplant care that a lot of people unfortunately lapse on. And it reminds me of a case, as I mentioned, in one of my transplant groups, of a man. He was getting ready for a major organ transplant, but unfortunately his support system, which was his wife, they had gotten a divorce, and so he had to be pushed down kind of on the list because he didn't have that mental stability, he didn't have that moral support, a caretaker, someone that can help see him through that.
So my advice for that is always communicate with your transplant team. Even if things don't seem that important, we have like social workers, nurses, people who are committed to try to help people through their transplant. But as I tell my patients, if we don't know what's going on, then we can't help you. So communication is always key.
100% communication, and as a big theme of this event is self-advocacy. Knowing when to speak up, knowing when to talk to your team. My kind of rule of thumb, if I even get so much as a tickle in the back of my throat, Dr. Sagana knows I'm instantly messaging saying, hey, this is going on. is there anything I should be doing? Is there anything I can do differently? And sometimes, things can pass on their own. It's not a big deal. But sometimes there are instances where, there needs to be intervention, antibiotics, screenings, etc. Which also brings me to a very important post-transplant question. It is becoming more prevalent that we know CFers, especially post-transplant with the immunosuppressant drugs, have a higher risk of developing some form of cancer. Do you happen to know offhand what type may be more common for post-transplants? Are there ways that we can prevent it? And how do we start the conversation with our care teams about our concerns about the immunosuppressant cancer risk?
Yeah, that's a great question. So as Ashley mentioned, being on immunosuppression, so the medicines that help prevent rejection of the transplanted organs, lowers your immune system. And it's your immune system that also helps your body fight off cancer. And so by being on immunosuppressants, yes, you are at risk for developing certain cancer in general. The most common type of cancer that post-lung transplant patient gets is actually skin cancer, specifically a squamous cell. And so I overheard Stephen in the previous talk mention this a little bit about being in the sun a lot, and people, enjoy being in the sun. But post-transplant patients really have to be careful about being in the sun. And it may not seem like a big deal. Usually squamous cell is what we call localized. It doesn't tend to spread, but it tends to happen on areas of sun exposure, and typically it's the face. And so as I tell, especially my younger patients, because they don't think about this, they feel good, they want to be out in the sun, and we live in Michigan, it's a big boating culture, and so everyone wants to be on their boat up north kind of thing. But I have older patients who, years after the transplant, keep getting little skin cancers on their face, and it has to be cut off. And so it's not fun to have cancer on your ear that has to be cut off, or your nose that has to be cut off, parts of it have to be cut off, or your face repeatedly. And so, so sunblock, a hat, avoid being in the sun at noon, all the things that we were told growing up kind of thing. You have to be very careful about sun exposure. Doesn't mean you can't be outside. It's just that if you're going to be outside, take precautions, try to avoid when it's the hottest, of course. And just kind of do your best to follow those kind of guidelines. The one thing I will mention specifically, so that's most common cancer for everyone, but in CF patients, the type of cancer that deserves special mention is colon cancer. And so maybe a lot of people already know this, but just having CF puts a person at much higher risk for colon cancer than the person who doesn't have CF. So colon cancer screening guidelines for CF patients actually start 10 years earlier than for other patients. Right now it's at 40, last I saw from the CF Foundation. That might be getting adjusted as colon cancer screening guidelines get adjusted, but for now it's 40. For post-transplant patients, it's even earlier. So once a person hits 30 and have a transplant, they need to be screened. If they get transplanted at, say, 32, has to be within like 2 years of that transplant. They should get screened. So it's just much more vigilant for colon cancer for CF patients, and especially post-transplant CF patients.
Yeah, that is definitely excellent information, because colon cancer has been a very large topic that we've been discussing, especially in the last year. And I do know that my team personally at U of M had brought that to my attention probably like last fall or something like that, which is, I'm going on 4 years post, and that was kind of the first time I was really hearing about colon cancer specifically. But luckily, I had my screening, everything was okay. But that is another thing you definitely have to advocate for yourself. If you feel, any sort of bowel changes, any sort of abdominal distress, anything like that, definitely bring it to your team's attention. See if there's anything that they can figure out for you. And same with the sun exposure, as you mentioned. I had to learn that on the hard way, kind of on my own. I think in the last couple of years, being on transplant drugs, which is for solid organs, you kind of forget, when you're out and you're having fun, that skin is just a large organ. And so the more you're exposed, your skin is exposed, your transplant meds are making that exposure almost amplify. And I contracted sun poisoning and ended up in the ER, I believe, a year and a half ago, just because I had completely forgot, oh, yeah, I'm on organ medications and my skin is an organ. I was still outside, even with, I carry an umbrella with me and make sure that I wear sunscreen slathered all over. So that is definitely something that I'm glad that you talked about and made everyone aware, because that was something I knew, and a lot of people, it going in that you have these higher risks, but when you're practicing it in your day-to-day life, it's really easy when you're living and doing things to have, like, oh, all of these precautions in the back of your mind. Okay. And we have a question about, how do you suggest we advocate for ourselves to get screenings for post-transplant?
Yeah, so great question. So the first thing is just knowledge. Like if you don't know that you're at risk for things, then you'll never bring it up. And so now that hopefully everyone in the audience knows that post-transplant people are at risk for cancer, that it should empower you to ask your transplant provider or the transplant team, hey, I know I'm at risk for cancer. What do I need to do? Uh, and so they should have information readily available for anyone that wants it. But yeah, the number one thing is being knowledgeable about this and asking questions.
Yes, I agree, and that is a very good point. Is like I said before, if even if you don't feel something's wrong, if you do feel something's wrong, obviously bring it up to your providers. But if you have a concern, you have questions, anything like that, your team is supposed to be there to help you. And it would be really great to know that more CFers are advocating for themselves to get these screenings, so that hopefully we can prevent more detrimental outcomes. There's another question about, it says, what about pancreatic, gallbladder, and a host of other cancers? We have a user whose daughter died of gallbladder cancer and is asking, what do you recommend in terms of routine screening for those cancers?
Yeah, so I'm very sorry to hear that you lost a loved one to such a rare cancer. So while skin may be the most common and colon cancer is up there, there are, yes, other types of cancers to consider as well. Second most common, at least for CF patients, is lymphomas. So there's a disease called PTLD, post-transplant lymphoproliferative disease. And so that's a type of lymphoma that can happen usually earlier after transplant, but not necessarily. I have another patient right now who's dealing with lymphoma, and he is, like 15-ish years out of transplant. So this is why it's important to get your labs when you're supposed to, like Ashley said, message your team whenever you're having any like weird kind of symptom. If it happens like once and then it's gone, okay. But if it lingers for like a couple of days and you're not quite sure what may have caused it, it's definitely worth mentioning it to the team. The problem with the rare type of cancers is that there is no accepted screening method on how to look for them in general. And so, because I also had another patient that passed away from a gallbladder cancer, And that person's was found just by, again, testing and finding abnormalities in their liver function tests. So there's what we call age-appropriate cancer screening. So that's when, for non-transplant, non-CF people, when you hit 50, you get a colonoscopy. For women, when you hit a certain age, you get your mammograms. So following those are definitely important. But again, because some of these cancers are so rare and they present in just different ways, and sometimes they're not cancer. Sometimes it can be really weird infections that can happen to patients. I had a young patient with CF. I thought with her symptoms, we did some testing, and I was very concerned about lymphoma and cancer. But she turned out to have a disseminated fungal infection, which could be almost as bad, except hers at least was treatable with antifungal medicines. And so we had to pivot and treated that. And now she's 2 years out and she's doing great. And so, but she would tell me like, hey, something doesn't feel right. Like I keep getting these weird pains and I don't know where it's from. And so that led us to do a bunch of testing until we figured out, what was going on.
And there was a comment in the comment session, I think during one of the previous keynotes from one of our users, Jerry. He had a daughter that passed from colon cancer relatively recently. And I just kind of wanted to touch on, he mentioned, don't just rely on your CF team for this information. Like you are able to, do some looking in. From my example, my recommendation would be learn what your blood work numbers mean, learn what those levels mean so that you know if something is off and so that you can bring it to your doctor's attention. Sometimes, some care teams for whatever reason can be stubborn or, can kind of delay action because maybe they have other things going on, but you're concerned about it right now. It's okay to be adamant about your own care. If you feel that that is something that's important to you, that you must get done, which I definitely do agree that you should, press for these screenings. Always advocate for yourself. Be stubborn with them. Send them multiple messages if you have to let them know that you are serious about getting these things done. Because as much as CF teams and doctors, and they are fantastic, they are amazing, but they are still people. Sometimes we forget to mention things even if we're doing it actively. So it's okay to also be aware of your own numbers, your regular health trends, and you'll be able to know a little bit easier if something's wrong and if you should be more stern with your doctors about getting screenings or testings or whatever it is you might need. I also had a question about, so one of the most common transplant questions that I actually get from a lot of people is when a CFer gets a lung transplant, does that pair of lungs still have CF? Does the person still have CF? And can the new lungs fill up with mucus in the same way that CF lungs can?
Right. So the transplanted lungs do not have CF. So as many people know, CF is a disease that affects at the cellular level. And so there's just errors within the genetic code of a person with CF that causes those symptoms to happen, filling up with mucus, things like that. So the transplanted lungs, the new lungs, do not have CF, but the rest of the patient still has CF. So their sinuses, their pancreas, their bowels, so all of that still has CF. And some of my patients, it's actually the lungs are great, they're doing awesome, but they're having problems with other parts of their body that we spend more time on trying to fix. So the lungs do not have CF, but the rest of the body still does.
And that touches on a great point that I was going to segue into. My post-transplant journey has, for the most part, been, pretty steady, which I have been absolutely thankful for. But I think that the two complications that I've had since then that required different hospitalizations or whatnot, I think I was about 4 months post-op, and I'm not really sure what happened. I think I might have just washed my face the wrong way, or because I was at a friend's house. But I developed a cellulitis infection in my eye, and my eye actually swelled shut. And I came across those photos recently, and it was just amazing, like how crazy that had gotten. And a lot of that was from my immune system being compromised from the immunosuppressant drugs. And the second most notable thing that I have developed since transplant is I now battle gastroparesis, and that kind of touches on, your lungs may not have CF, but the rest of your body does. And it could be a combination of a bunch of things, but I do know that, the extra medications, the new routines and whatnot, it definitely has a factor as to why my stomach now empties slower than it used to pre-transplant. So CF is a very interesting disease in that way. Okay, we have a question here that says, should your CF center or doctors and your transplant doctors routinely be proactive with their patients on cancer risks? It seems like the burden is on the patient. Should there be standards for post-transplant cancer screenings? Dr. Sagana, what would you like to see if you set those protocols?
Sure. So transplant teams should be proactive when it comes to reviewing a patient's cancer risks, and it starts by having conversations about the transplant medications, the side effects, and about cancer in general. So that's what we try to do in our system, is to have these conversations, and we keep track of everyone who needs a colonoscopy. And if anyone here in the audience has had a colonoscopy, it's not a fun thing, and it's especially not fun in a CF patient because it just takes a lot to get the prep done. So being cognizant of those issues is important. I hope this is coming more across as a partnership. And so as I tell patients, there are some things that just modern medicine hasn't figured out yet. Maybe one day we will, and as Ashley's been alluding to, we've always worked to try to get to better places in how we diagnose and how we screen and things like that. But there are just some things that just aren't possible at this point, because everything has potential side effects. So if we got a CAT scan every 6 months in someone, a head-to-toe CAT scan, that might pick up on some cancer sooner, but the radiation from that would also cause problems and actually also may cause cancer in that person. So there has to be a balance between what we do and what's best for the patient. And as medical science tries to improve and get better at diagnosis and guidelines, then for now, we have to, like I said, have a partnership between the care team and the patient. So in terms of like protocols, again, I would just say talk about these kinds of things early and establish a good relationship between the patient and the team so that the patient doesn't feel like they're being a burden by reaching out and contacting their team. I always think about that one patient of mine who, she just kept saying this weird pain, like it's just not getting better. And so we kept looking. And so I'm not sure how we would have found it out if she hadn't kept saying, there's just something wrong. And so that's where it has to be a partnership. She told us, and I'm glad we listened, and we were able to diagnose and have a good outcome for her.
And it's interesting, they mentioned protocol. I had seen in the chat during the previous keynote, because Stephen and Leslie had talked about, your original CF care team and your transplant care team are often two separate areas. So it's almost like, these people have followed you for so long, and now you kind of have to say goodbye and meet this whole new team and get to know them, develop that rapport. Here at U of M, actually, as I mentioned in my introduction, I am on a medical advisory board for U of M, and my previous CF doctor is on the same board with me, and we discussed having your previous CF doctor also being able to check in with you during your transplant visits, I think for the first couple years or whatever it was that we are beginning to adopt. And luckily, I have seen a couple people agreeing in the comments that, oh, I wish that my team did this. And then there's other people who said, oh, yeah, my team has been doing that for a while, and it's been really helpful. And as I mentioned a lot about, advocacy and, speaking up about things like that, it's always really great when you have that cooperation, like you said, that partnership, where it's another pair of eyes looking out for you. It's another set of hands that's digging through all the information, trying to make things link up and make sense for that patient. So I'm very excited about the protocols that U of M has been instating, as far as being able to have that continuous rapport, so that we have more people kind of, in our corner, because that's what it is. It's a partnership. We're all trying to have the same goal, which is having a patient with CF to have a better quality of life, despite, what they've had to get through to get to that point. Let me see here. And this is actually an interesting question that I got from social media recently for you, Dr. Sagana. If a transplant recipient is an organ donor and passes away, can they donate their organs? Can they also donate their donated organs?
Sure. So it's a very interesting question. So for let me start with this. Anyone post-transplant person can sign up to be an organ donor. There's no restriction for that. At the time of donation, when the person passes away, there's a team of specialists that Gift of Life that will review the person's records and will see like what organs would be viable for transplant to give to someone else. So that happens, and so if you are a transplant recipient, you can still sign up and be an organ donor. It's just harder to have things donated because there's a lot of things that have happened to a person's body after transplant. Specifically to lung transplant, it is generally not possible to donate those lungs. And the biggest issue is once a person has been transplanted and those lungs have been sitting in the new chest and has been there, it tends to scar in place. And so to get those lungs out and into a new person would be extremely difficult for the surgeons. A CF person's lungs are actually very hard to get out in the first place because of all the inflammation and mucus and infections over the years. It's really kind of scar down those lungs to your chest wall. And so, yeah, I've heard my surgery colleagues talk about literally scraping the lung off the chest wall. It can cause bleeding, yep, and all sorts of issues. So that would make it extremely unlikely that lungs that have already been in a person as a transplant could be harvested to give to another person. I have seen reports of other organs. I just saw something about a kidney that was in a person, and then the person passed away from something unrelated to their transplant, and then they were able to use that kidney for another person. So again, with advances in medical technology, who knows what will be possible? But yeah, for lungs, most likely no. But for other things, unclear. So sign up. Everyone should be an organ donor.
Yeah, and that is really interesting. It was kind of funny that you mentioned how they adhere to your chest wall, and that was an issue that my transplant surgeon had a problem with my situation because I had those three separate, pretty large pneumothoraxes by the end, and as I had mentioned in the chat, I was lucky enough that I asked my team if they could get photos of my old lungs and my new lungs by chance, if they were able to, and they were able to oblige. So I actually have physical photos of what my old lungs look like, and it was very surprising to see the differences between the old lungs and the new lungs. Whereas, these ones, they were so sticky and they had to, be scraped out because it was just full of mucus and infections, and the holes had caused all kinds of seeping and all of that stuff. And then you look at the lungs that were about to be transplanted for me, and they are just so pretty and pink, and they don't look angry and red. And so it is really interesting, the things that your body will go through during and after transplant just because of the CF being in your lungs. Well, let me see. Let me see if we've got anything else here. Are there any advancements that you personally have seen in the last few years that gives you hope for the CF community?
Yeah, so in general, one of the things is Trikafta, which I'm sure most people in the audience are familiar with. Uh, so our center used to do 5 to 8 lung transplants for CF patients a year. Within the last 3 years, actually this just past 6 months, we've done 2, but which was unusual. But the year before that and the year before that, we did 0. In 2019, we were kind of catching the tail end of people who didn't benefit from Trikafta just yet. And so we had a couple that year. But Trikafta has really changed how we think about lung transplant, because so many patients just feel better and get better on Trikafta. And so we're still figuring out what that means for the future. And they're finding out that Trikafta may have some benefit in people who don't necessarily have the Delta F508 mutation. And so that's still getting sorted out a bit. So I'm curious to see how that plays out. So there's that element, but then there's also Trikafta post-transplant. So Trikafta post-transplant will not have anything, it won't benefit the lungs. Because again, as we said earlier, the lungs don't have CF, but it can benefit other parts of the body. And as Stephen earlier said, his sinuses got much better when he was on Trikafta. So we will put someone on it for sinus issues. We will put someone on it for weight issues. Typically, the weight gain is about 10%. Some people, it's a lot more. Some people, I think, like Stephen said, he didn't benefit from the weight gain. So that's a little variable. Yeah, so we're still trying to figure out how Trikafta will ultimately fit in the care of the post-transplant CF patients. But at least for pre, that's been just something tremendous to see over the last couple of years.
I agree. And that was actually one of my next questions for you. How many, from what I gather, putting a CF patient that's post-transplant on Trikafta is more of a rare occurrence right now. Could you possibly say how many you approximately have overseen that you've had on Trikafta?
So I personally take care of between 40 to 50 post-transplant CF patients, and it would be under 15. My nurses say I always underestimate things, but I would say it's under 15 that are on Trikafta. And the reason for that is Trikafta can have side effects. And so we've had a couple of patients where we put them on Trikafta for this issue or that issue, and they had horrible stomach pain. with it, or their liver function tests went super high. And so one person said it affected his breathing. I don't know if I believe him, but that's what he said. So we had to take him off Trikafta. But everything has side effects, so you have to think about that. And also, if someone's doing well, then I don't want to add something that we're not sure exactly what happened. So I have this conversation with my patients where we'll ask, hey, or I'll say, like, I don't think you'll benefit from that Trikafta. You're doing great. And 9 times out of 10, they'll say, yep, I agree. I don't want to be on Trikafta, kind of thing. So again, it's just a conversation that we have about it. And as there's more research done with this, we'll see where things evolve. And as people probably also know, Trikafta is super expensive. And so we want to be mindful of the limited resources that there are. And so we want to try to target people who we think will have the best outcomes when we put any medicine, give them any medicine. So that's another thing we have to kind of keep in mind. We tend to be a little bit more liberal with Trikafta here than some other centers that I've talked to, where we're more willing to try it and see what happens. And if it doesn't work, it doesn't work.
Okay. Yeah, because as I had mentioned before, I don't have experience with Trikafta per se, but I was in the research trials. It was funny. I actually just came across a photo of me from, I think, 2013 when I was in the research trials for like Symdeko and Orkambi, which during that period in my life, for me personally, it did help, and I gained a little bit of weight for a while. My mental health was pretty stable as far as someone in their early 20s can be, but otherwise I had like a couple years where I wasn't getting colds and stuff like that.
So we're coming up on time. Let me ask Ashley a couple questions then. So how about this one? What surprised you the most once you were post-transplant?
I would say probably the most interesting thing that I was very surprised by, and one of my post-transplant buddies kind of warned me about, but you don't think about it, was the first month or so that I was home. Of course, being in the hospital bed for an extended period of time, you lose that muscle mass and that strength in your legs. And just getting up the stairs was oh my goodness, it was such a difficult thing. And I had maybe like, I think I have like 5 stairs to get into my house. And even going up those, I felt so weak in that moment. And it was one of those times where it was just like, oh my goodness, if I knew everything was going to be this hard, maybe I wouldn't have done it. But it was one of those things that, luckily after a few months, after I was able to gain up my strength, get some weight back, and, have my lungs actually begin to expand, it was a lot easier to gain that strength. And speaking of, one of the other very surprising things post-transplant is, like I said, is you kind of have in your mind this fairy tale idea of, you're going to wake up, you're going to get the vent out, and then you're going to breathe, and it's going to be easier. And then you can go home and, do all the stuff that you love to do, which is true, but it's definitely through rose-colored glasses, because I believe it took me close to a year to feel, a little more stable. It took several weeks, several months for even my chest cavity to expand all the way. I think Stephen had mentioned, year after year, sometimes his lung function was improving post-transplant. And that's kind of what was happening with me, which was very surprising, is, getting out of it. It's really hard, really painful, and you're able to breathe a little bit better, but it still kind of sucks and everything's tight and it hurts. But then after like 4 to 6 months, oh my gosh, I've got other parts of my chest cavity that's opening up, that's like unlocking. And now I have a bigger, deeper breath than I've ever been able to imagine. So that definitely took me by surprise at the length of time that it took me to recover, but it was also surprising how quickly, it all kind of went by. So it's kind of a contrast. It's really long and it's really hard, but at the same time, it kind of goes in a blink of an eye, and you're kind of in this position where, okay, now what do we do?
Yeah, well, you're really busy post-transplant because you have all these appointments you have to get to. You go back to pulmonary rehab. And so I guess that's another thing I would mention that Ashley's been expanding on, is that it's a lot of work. Like, it's a lot of work to get to be able just to be put on a list. And it's a lot of work after transplant. And yes, the goal is to get you to do all the things, fun things that Ashley's been able to do with her time, but she worked very hard to get to that point. So it's, again, partnership. I always stress partnership when it comes to this. We can do a lot to help a person, but we can only do so much. We can't force the person to exercise, to make sure they take their meds and all the other stuff. So hopefully by the time we get to that point, both sides are kind of working in sync to get the patient to the best possible health outcome.
Yeah, and I definitely agree with that, because it kind of goes into what I was saying about advocacy. Not only advocacy towards your CF team and your care in that way, but advocacy toward yourself. Getting to know yourself, getting to know this new version of you, getting to know the new routines that you have to go through, or really it comes down to whether or not you can buckle down and really focus on what you have to do as far as like your diet, your precautions. And as he mentioned, you have a lot of follow-up appointments. Like the first 3 to 6 months are really intense because everyone, is trying to make sure that these lungs are being stable for you, that you're doing the things for them that will help them and that will help you thrive in the long run. And it is a lot of work. And I feel like a lot of people don't really think, oh, I kind of tell them I'm constantly in the back of my mind thinking about food because, I have to know when to eat, what quantity, what types of foods. I have to balance it along with my medications and then my enzymes and all of that other stuff. But I think it really does come down to being able to pay attention and like we said, get to know a team, get to know yourself, get to know everything that goes into it, and really work for yourself, work for the life that you're trying to lead from there.
Yep. All right.
Okay. Well, it looks like it's about time to wrap up. But I enjoyed this discussion. I am so honored and thankful that you have joined us and was able to give your insight, Dr. Sagana. Really appreciative of all of your time and efforts and all of the work that you do at U of M.
Well, thanks, Ashley. Thank you for inviting me, and thank you for all your hard work too, not just as a patient, but as an advocate for all CF post-transplant patients. So I really appreciate the work you do as well.
Thank you so much.
Well, that was a fantastic discussion. I learned a lot. Somebody pre-transplant, waiting to go through that at some point in the future. Definitely, fantastic conversation. I learned a lot. So thank you, Ashley, too, for conducting that and having that conversation with Dr. Sagana.
Yeah, I really hope that it was informative and kind of gets some perspective so that everyone knows, you can talk about these things. It's good to speak up. It's good to talk for yourself and talk to your care teams.
Absolutely. And I'm hoping everybody has really enjoyed the last 2 days of NextBreath. I think just from the keynote today and then the other small group discussion that was going on simultaneously to your conversation, I hopped in there too, and they were having some really, really interesting, sharing some great thoughts and, perspectives for one another. I think it's just so great to have this community, come together, and we learn from one another, we support one another. And, that's what this is all about, hosting these type of virtual conferences and virtual events for us.
Agreed.
Well, I think that wraps up our time. Everyone, again, thanks for joining us. And, in the chat, we'd definitely love to hear from you more about what you've taken away from this event, and certainly hope to see you again at future NextBreaths and other virtual conferences too, like BreathCon and ResearchCon. Those will be coming up next year. I think they already happened earlier this year. But yeah, Ashley, is there anything else you wanted to add?
I think I touched on most of the topics that I was trying to get to. I really appreciate everyone's time, everyone's participation. Like Ella said, those session rooms have been popping off, especially this evening and yesterday evening. It has been amazing to see everyone being able to communicate, share their experiences, whether it's unique or if it's a shared experience. It's just it's a wonderful feeling to be able to have this community that we all pretty much know, where each other is coming from, and we all feel pretty close from that connection alone. So I'm really honored to be a part of this. I'm so honored to have been a co-chair next to you, Ella, and thank you to everyone working in the background that's put this on and made it possible. We have had a fantastic couple of days.
Yes, and likewise, it's been great to share this with you, and to all the planning that went into this, and thanks to all the other speakers, the facilitators, and all the other volunteers, CFF staff, as you said. Couldn't have done it without your involvement and support. So with that, well, I think we'll say good night, and hope to see you all at next year's event too. So thanks.
Yes, good night.